Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I'm pleased to welcome you to the multimedia summary for the journal's January 2021 issue. There are 4 articles, 3 of which focus on COVID-19, that have been selected as our Editor's Choice or Highlights articles this month. Our Editor's Choice this month is an original article entitled Association of Infant Antibiotic Exposure with Childhood Health Outcomes. It is authored by Dr. Zira Aversa and colleagues from Mayo Clinic in Rochester, Minnesota, and Rutgers University in Piscataway, New Jersey. The growing specter of antimicrobial resistance threatens to vitiate the remarkable innovation and progress made in the field of antibiotic discovery and development. Such resistance reflects the versatility of bacteria in developing strategies that surmount the bactericidal and bacteriostatic effects of antibiotics. A major underpinning of this phenomenon is the widespread prescription of antibiotics, especially in the absence of a justified indication. In the present issue of Mayo Clinic Proceedings, Aversa et al. Point to another concern with antibiotic usage: the occurrence of unexpected diseases in childhood following the exposure to antibiotics in infancy. Using the Rochester Epidemiology Project Medical Records Linkage System to identify children born between January 1st, 2003 and December 31st, 2011, these authors extracted data pertaining to demographic features, disease diagnostic codes, and antibiotic prescriptions in the following years until June 30th, 2017. The study population comprised almost 15,000 children, with boys and girls each numbering more than 7,000. In the first 2 years of life, 70% of children received at least 1 antibiotic. Girls and boys who received at least 1 course of antibiotics exhibited a higher incidence of asthma, rhinitis, being overweight, and attention deficit hyperactivity disorder. Atopic dermatitis and celiac disease was significantly increased in girls, and obesity increased in boys. The risk for increased occurrence of certain diseases depended on the number of prescriptions received. For example, for children receiving 1 or 2 prescriptions, girls but not boys were at an increased risk for celiac disease and asthma. With 3 or 4 prescriptions, both girls and boys were at an increased risk for asthma, atopic dermatitis, and being overweight. With 5 or more prescriptions, either sex exhibited a higher risk for asthma, allergic rhinitis, obesity, and attention deficit hyperactivity disorder. The risk for subsequent disease depended not just on the number of prescriptions, but also the antibiotic prescribed, with cephalosporins associated with the widest range of conditions and a relatively specific susceptibility to autism and food allergies. Children who received antibiotics, especially multiple prescriptions, were more likely to exhibit dyads or triads of disease. The strengths of this study are multiple, including in particular its interrogation of a unique database, the Rochester Epidemiology Project, that enables long duration of follow-up, accurate determination of antibiotic prescriptions, and the accurate documentation of a range of childhood diseases, not just a single disease, as is commonly available in published studies. The authors point out that these findings are associative and not causal, and that limitations in interpreting their findings may stem from confounding by indication or reverse causality. Nonetheless, these findings are not only important and timely, but they are also concerning as they point to the risk of childhood diseases that attend prior antibiotic usage. These studies thus underscore the need for judicious prescribing of antibiotics in infancy. Additionally, the findings of Aversa et al. Set the stage for preclinical and clinical studies that can test causality. Finally, as percipiently discussed by the authors, these findings draw attention to the role of the microbiome in determining homeostasis and health. From birth onwards, the microbiome that progressively gathers in the growing infant and child exerts abundant salutary effects, including those that promote immunity and the healthy development of major organs and metabolic systems. Impairing the microbiome by antibiotics, especially during such nascency, may predispose conceivably to subsequent childhood diseases. Our first highlight includes two brief reports. The first is entitled Effectiveness of Physical Distancing, Staying 6 Feet Over to Put Respiratory Viruses 6 Feet Under. It is authored by Dr. Catherine Freeman and colleagues from Mayo Clinic in Scottsdale, Arizona. The second one is entitled Risk of SARS-CoV-2 Transmission Among Co-workers in a Surgical Environment. It is authored by Dr. Mark Paculo and colleagues from Mayo Clinic in Jacksonville, Florida. In this issue of Mayo Clinic Proceedings, these two articles demonstrate that adherence to recommended practices to prevent viral transmission are associated with salutary outcomes regarding the circulation of respiratory viral pathogens in a general community and the transmission of SARS-CoV-2 in a specific community. Freeman et al. Used a BioFire film array respiratory panel performed on nasopharyngeal swabs to evaluate the seasonal profile for respiratory viral pathogens detected during the months from April and July, before, that is, 2017 to 2019, and after, that is, 2020, the start of the COVID-19 pandemic. From April 2020 onwards, such Centers for Disease Control and Prevention recommendations as physical distancing, masking, and frequent hand washing were commonly followed. Freeman et al. Show that during these months in 2020, as compared with the same months in the 3 prior years, there was a steep decline in the percentage of positive tests, with monthly test positivity decreasing from 25% to 2%. The test results in 2020 were notable from 2 additional perspectives. First, the decline in 2020 was observed in particular for rhinovirus and enterovirus, the most prevalent respiratory viruses circulating in the community. And second, there was a stark absence of double positive tests detected during these months in 2020, whereas double positive tests occurred in more than 3% of reports in prior years. These findings are complemented by those of Paculo et al., which are derived from examining SARS-CoV-2 transmission in a specific environment, that is, healthcare workers in a surgical environment. These are healthcare workers who were exposed to 2 co-workers who tested positive for SARS-CoV-2 towards the end of March 2020. In this surgical environment, as is generally true for surgical units, standard precautions were in place and the use of surgical masks quite prevalent. Surveillance testing was conducted of all healthcare workers who may have had workplace contact with these index cases. Notably, of the exposed 394 healthcare workers tested, only 1 case was positive, and on repeat testing 1 week later, in 387 of these healthcare workers, no additional cases were detected. Paculo et al. Conclude that the risk of spread of SARS-CoV-2 in healthcare environments in which personnel comply with masking and hand hygiene procedures is relatively low. In discussing how to restrain a different phenomenon from spreading, namely fires in the city of Philadelphia, Benjamin Franklin wrote in 1735 that an ounce of prevention is worth a pound of cure. This now long embraced cornerstone concept in medical practice underpins the findings of Freeman et al. And Paculo et al. And emphasizes relatively simple practices and behaviors in preventing viral spread, including those pertaining to SARS-CoV-2 in the current pandemic. Our second highlight is an original article entitled Socioeconomic Disparities in Community Mobility Reduction and COVID-19. It is authored by Ashley Osimetha from MD Anderson Cancer Center at the University of Texas in Houston, Texas, and colleagues from Brown University in Providence, Rhode Island. Susceptibility to COVID-19 may be increased and outcomes from COVID-19 worsened by personal characteristics. For example, age, male sex, decreased cardiorespiratory fitness, obesity, and by comorbidities, for example, pulmonary diseases, cardiovascular diseases, diabetes, hypertension, cancer, and the immunosuppressed state. In the present issue of Mayo Clinic Proceedings, Ossimatha et al. Addressed whether an association exists among socioeconomic disadvantage, community mobility reduction, and outcomes from infections with SARS-CoV-2. Mobility reduction reflects social distancing, a central strategy in confronting the COVID-19 pandemic. In this study, mobility levels were obtained from Google COVID-19 mobility reports, which provide data on the change in frequency of visits to specific places as referenced the baseline time frame before the onset of the COVID-19 pandemic. Places assessed in the current analysis included workplace, grocery and pharmacy, and retail and recreation. As for these places, relatively complete data were obtainable by the authors. Cases of SARS-CoV-2 were determined from the database maintained by the Johns Hopkins University Center of Systems Science and Engineering. The Social Deprivation Index, hereafter referred to as SDI, was used to assess socioeconomic disadvantage. SDI is an integrated county-level index that incorporates 7 socioeconomic elements, including, for example, living in overcrowded housing, unemployment rate, and poverty rate. The findings in the study by Ossimatha et al. Demonstrate that counties with high SDI had increased percentages of Black and Hispanic populations. Counties with greater SDI as compared with counties with lower SDI exhibited low mobility reductions for workplace, grocery and pharmacy, and retail and recreation. And counties with a greater SDI exhibited a higher number of SARS-CoV-2 infections and deaths. Thus, economically and socially disadvantaged communities are more vulnerable to SARS-CoV-2 and have worse outcomes. As underscored by Ossimatha et al., testing for SARS-CoV-2 and the tracing of contacts are especially required in these communities. Socially distancing is universally recommended as another strategy, but achieving this in communities with a high SDI and a low mobility reduction may be challenging for a number of reasons speculated upon by Ossimatha et al. Long before the start of the COVID-19 pandemic, abundant literature attests to the fact that the risks for assorted diseases are markedly influenced by social determinants. The current study of Ossimatha et al. Persuasively adds to the mounting evidence that the same is true for infection with and outcomes from SARS-CoV-2. You can access these highlights and editor's choice articles free of charge during the entire month of January. When you visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, you'll find links to our social media by clicking the buttons at the top of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, 60 seconds video article synopses, and our Mayo Clinic Proceedings issue summary and Author Insights podcast recordings, which are available from our website on the home page, as well as through iTunes. You'll also find our online-only feature, Pioneers and Legends in Medicine, which are video interviews of people who've made a strong impact in their field of study. You will see many news stories at our website that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content and articles published online ahead of print. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.